Good afternoon, and thank you for joining us. My name is Jose Leon. I am the Chief Medical Officer for the National Center for Health and Public Housing. Welcome to this panel discussion on COVID-19 vaccination and testing, promising practices, lessons learned, and challenges. The National Center for Health and Public Housing provides training and technical assistance to community health centers with emphasis on providing training to those health centers located in or immediately accessible to public housing. We are funded by HRSA to provide training and technical assistance. And this is a picture of all health centers and public housing developments. All these are clinical sites. So we are very pleased to work with more than 385 health centers located in or immediately accessible to public housing. To discuss or have a conversation about public housing residents is a great opportunity to also see at the social determinants of health. As we know, social determinants of health will affect the response to the COVID epidemic. We already know that patients, minority patients, or those with who are either race, they are part of the race or ethnically minority, are more likely to test positive and have complications from COVID. So I am very pleased to have 3 health centers who are being willing to participate and who are very supportive and who's been helping the National Center for Health and Public Housing for many years. This is a great occasion to ask questions. This is a great occasion to interact with them. All the 3 health centers have the expertise, have been struggling, have been dealing with COVID the same way that everybody has been. So feel free to chime in, feel free to either type your question, to either unmute yourself and ask questions, or if you are on Facebook and you are watching this presentation on Facebook, you can also type your question and then we are going to read your question aloud. So it's I'm very pleased, I'm very happy to have the health centers today and the panelists. I'm going to start with Dr. Rina Ramirez. She is an internal medicine physician and chief medical officer of Zufall Health Center, a federally qualified health center based in Dover, New Jersey. Zufall offers primary care services to the general community as well as residents of public housing, persons experiencing homelessness, and farm workers. Dr. Ramirez has led Zufall Health Center's expansion of clinical services through participation in collaboratives and implementation of an interdisciplinary model of care. Dr. Ramirez continues to promote innovative practices and excellence in healthcare outcomes by fostering teamwork, supporting a strong QI/PI framework, and implementing an integrated model of care with medical behavioral health, dental, and HIV services. Thank you, Dr. Ramirez, for joining us. Then we have Mr. Henry Taylor. Mr. Henry Taylor is a Chicago native, spent most of his formative years on the south side of Chicago. He was formally educated via the Chicago Public School and received his master's degree in public administration from Roosevelt University. He has also completed executive management training at University of Pennsylvania, Wharton School, UCLA University of Kentucky, and Harvard. He has over 20 years of healthcare administrative experience in the private, nonprofit, Catholic, and public sectors. He's passionate about patient rights to healthcare. He continues to advocate on a national and local level for the rights of individual patients and actively lobbies for increased access to healthcare for underserved families. He currently serves as the chairman of the board for the Illinois Primary Healthcare Association. In addition, he has served as past chair of the National Association of Community Health Centers, Task Force on Primary Care for Public Housing, a member of the board of directors for Sequest America, past board member of the Chicago Children's Choir and volunteer for the Boy Scouts of America. Mr. Taylor has been with Miles Square since 1998. And last but not least, we are very pleased to have Dr. Javier Rodriguez, who has been a California licensed pediatrician since 2003 and was certified by the American Board of Pediatrics in 2004. Dr. Rodriguez joined the medical team at La Maestra Health Clinic, a federally qualified health center, in 2004, and has worked in general pediatrics at the organization for more than a decade. In September 2011, Dr. Rodriguez was promoted to medical director, and in 2017, he became La Maestra's chief medical officer. In his current role, Dr. Rodriguez is a practicing pediatrician as well as the CMO. As the CMO, he leads a qualified team of physicians that represents the diverse cultures and the communities served in Central, East, and South San Diego County, California. Also, it should be noted that all of La Maestra clinics are located within the border region. So thank you so much, Dr. Ramirez, Henry, and Dr. Rodriguez for being with us. So we are going to start just giving a very brief introduction of COVID. We were just discussing before going live about the challenges, how the pandemic has evolved, how we have moved from different stages, from being afraid of a new pathogen to provide the preventive services, to helping people and educating people on wearing masks, on washing their hands, and all the preventive services and prevention measures that we have to have. Then we move to telemedicine, to workforce retention and burnout. So there have been several challenges, and now we went to the testing period, so everybody could get tested and try to determine who was sick and what we could do for our sick patients. And then now is the time to start vaccinating our patients, to try to get our patients immune and vaccinating our higher risk groups. And now probably in the future, we will be discussing some treatment guidelines and what to do with some of the patients in outpatient facilities. So thank you again. The reason for this, so basically this time we are going to discuss two particular issues. One is going to be vaccination, and the other one is going to be testing. So the very first question is on testing, and I would like to ask Dr. Ramirez about any issues regarding vaccine distribution in New Jersey. New Jersey is very close, if not at the epicenter of the epidemic when we started having new cases. So now we would like to hear from you about the vaccine distribution, who you are talking to, who is responsible for, and what are the challenges and best practices at Zufall Health Center.
Thank you so much. I'd like to answer that question. It's definitely been a challenge, but like what you said, Jose, at the beginning, through all the development of our activities as response to the pandemic, we learned through that process, and every single lesson learned will help us and has helped us in tackling the next wave or the next situation that we are faced with, so that when we first started working with patients in telemedicine and then teaching them about prevention and then doing the testing, all of that has really, really built on each other. And the only thing I can say is that we have three things that are really important for our success. First one is leadership commitment from our management team, our CMO, our CFO, our CEO. Everyone is committed to this new path that we have to take and this new activity. The second one is clear communications with our employees and our patients. And the third one is definitely our community partnerships. That has been so instrumental in any successes that we have had. So for the testing success and vaccination success, our community partnerships with public housing authorities and with the State Department, the Department of Health in New Jersey, has really helped us be on their radar as people, as an entity, as organizations that can really help get to the most vulnerable, which is one of the issues that we're having with vaccine equity and access. So we have been recognized by New Jersey Department of Health as very important and key participants and partners throughout the state in order to be able to provide the vaccinations. Based on that, we were able then also to work on things that we have worked on before with the Department of Health. They gave us funding to do flu vaccination, and we got really good at vaccinating a lot of people. And we staffed up a little bit to get more nurses on our team, which we never had. So that was also very, very positive. The second thing was that we also started doing a lot of COVID testing. And again, just looking at the staff and the workforce and how you stretch that workforce to identify people that you would otherwise not really initially have on your staff, what has been also very helpful, because the challenge of vaccinating against COVID is very, very big. It's very labor intensive, it's very time intensive. There's a lot of data to put in, there's a lot of reports that everybody wants. So we need to have that developed workforce. So every step of the way helped us to get to the point where we can do this, both at our sites and also at public housing settings. And we have already gone out to at least 3 public housing settings to vaccinate our residents of public housing.
Thank you, Dr. Ramirez. And this slide shows the results of the data that HRSA is getting from all health centers, specifically those located in or immediately accessible to public housing and public housing grantees in regards to the challenges in deploying the COVID-19 vaccine. The main challenges are vaccine storage capacity, vaccine confidence, financial reimbursement for costs associated with vaccine administration, staffing issues, and then the vaccine supply. So I would like to ask Mr. Henry Taylor regarding a question on the financial reimbursement. This is a very important topic for health centers. We have heard that the cost of the vaccine is free sometimes, but there are other expenses associated to the vaccine, specifically when it comes to the wages and everything else that supplies that are associated to vaccinating our vulnerable populations. So Henry.
Indeed, thank you so much, Jose. Let me start by just sort of giving a backdrop of 2020 for Miles Square Health Center. We're a little different because we are associated with a university system, so we have a few more resources to draw upon. What you're seeing on your screen is the 7 regional health sites we have at Miles Square, but it is important to note that we have 6 school-based health centers as well, for a total of 12 centers overall for Miles Square Health Center. What we have experienced is first a 25% decline in our overall patient revenue as a result of the onset of COVID. So I think that's important to start our conversation. And that has netted over $2.5 million in revenue loss for our practice for fiscal year 2020. And as we go into 2021, which we're currently in, we're still recovering from the reduction in patient volume that has affected our health center. It's important to notice we have managed through this process. We did not close any sites. We did not lay off any staff. We have sort of struggled and suffered through this as a commitment not only to our community, but to our staff. But we're working hard to come out of the pre-COVID kind of experience. One of the challenges, as you alluded to, Jose, is the old adage, how do you occupy 2 spaces? And let me further explain that. We run a day-to-day practice at Miles Square Health Center, very robust clinic, even though we've seen a 25% decrease in volume, we still have to run our day-to-day business and in fact, run a COVID testing site at each of our clinic locations. So we are testing at each of our clinical locations, and I'll explain why. In addition to partnering with the University of Illinois to have mass testing at our Mile Square site on Roosevelt Road. So we've been pretty well engaged in doing an enormous amount of testing for our community and for the Chicagoland area at large. One of the reasons this is a commitment by us is because the communities we serve are largely brown and African American by nature, and we know that they suffer largely by large disproportion from the COVID illness, and deaths are twice as high in African American and brown communities. So it's incumbent upon us to be a resource through the community to abate that. One of our sites, in fact, is in Chicagoland, one of the highest communities death rates in our South Shore community, where we have a site and we are actively, testing to abate this virus. So we're on the testing side of the equation now. What's important to note also in our practice as we look at the testing, and I'll get to more of your question about the finances, is not only have been involved in the testing, but our staff have been involved in a number of research studies to improve or to provide data for our scientists at the University of Illinois to do the nasal swabs as opposed to nasal pharyngeal, that we've gotten that approved. So now we are moving to nasal swabbing as a result of the data and research done by University of Illinois, and also saliva testing are going to be new ways in which we approach testing for COVID. So as I look at the major question, the major challenge for us or for us in the city of Chicago is through the Illinois Department of Public Health, we are getting the vaccines free of charge. That's the good news. What's not covered is the additional costs to set up vaccine centers or vaccine systems within your same center. For us in Illinois, we are just we don't have the capacity for doing a Pfizer inoculation at our FQHC because of just the technical challenges associated with the Pfizer vaccine. So I want to put that, say that rather plainly. However, in partnership with the University of Illinois, we have established a centralized vaccine center at what's called Credit Union 1, which is a large arena that's owned by the University of Illinois, that we're inoculating all of our patients 65 years and older, which is considered class 1B in terms of that vaccination process. Now, we're in our partnership, we're doing that as part of our process, but also we're migrating to having the COVID testing in inoculation become part of our normal practice process. That's important. For example, when our patients come in who are 65 and older for their routine office visit, these vaccines are being offered. This inoculation is being offered as part of their practice. So that's layer one. Layer two will be our having open community-based inoculation programs associated with our practices as well at each of our 7 regional sites. So as you can see, by trying to do all of that, it does beg the question, how do you fund this outside of the vaccine? Because you have to have staff, you have to have MAs, you have to have RNs who can manage this work, you have to have staff who can manage the process, the flow. Fortunately, we have seen philanthropy, a number of foundations step up. And in fact, they've reached out and has asked, how can we help you? Knowing that we are serving and addressing the needs of those populations that are hardest to reach. We want to look at our strategy relative to when we look at those individuals who are less likely to come out and get to the clinic. So part of our testing process is not only by appointments, but it's for walk-ups as well. So you can walk into the clinic and get appointments. But Jose, I can share with you that there is a big financial burden. We did suffer a loss as a result of 2020. It was just part of our commitment as an FQHC. We absorbed that. We're absorbing that loss, but we're still committed to being of service to our community by being available to these community residents who need the service. I think most important for us is to recognize that we are a trusted source, FQHCs across the country. We're a trusted source. So even if it costs us something, at the end of the day, I don't know if anyone else can do what we can do in terms of being where patients need us the most. One of your panelists, you mentioned a physician on the panel as a pediatrician, and they're on the border. Who else is going to be available if we're not there to meet this population's need? That's highly valuable. I hope that helped.
Thank you, Henry. That's very useful information. Again, I would like to remind the audience that if you have any questions, if you would like to ask a question to any of the panelists, please either type your question or just unmute yourself and ask your question verbally. And it's my pleasure now to have Dr. Javier Rodriguez with us from La Maestra Health Center, very close to the border, US-Mexico border. And Dr. Rodriguez, the question is, we are talking about minorities. We are talking how likely they are to have COVID-19 and complications, and even being affected by death and everything else. La Maestra serves not only African American and Hispanics, but you have a very large population from all over the world. So what are the challenges to educate your patients and at the same time to make sure that they receive the information on testing and vaccination?
Well, Dr. Leon, thank you for having me first and foremost. It's a pleasure being here, and sorry I was a little late. I must have missed the calendar invite, but it's okay. I was here finishing patient care, and I said, okay, I'm going to jump in. I'm actually here in our isolation room. We have here in pediatrics when we have a suspected COVID case. So we put them in here, and so hopefully there isn't one. If there isn't, I'll have to move, but it's okay. But I just wanted to say that that a lot of the information that Mr. Taylor shared and Dr. Ramirez shared, resonates so much, what we're doing here in the community here near the border. I mean, yes, there are some, nuances and differences there, but like Mr. Taylor said, who else is going to really do this? Who else is going to eat the cost so that the right thing is done, and that's us, all of everyone that's represented here in this, in this Zoom meeting and this conference, it's a pleasure to be here. But speaking of the question at hand, yes, we do have a lot of different languages that are actually just even spoken in our staff. La Maestra has always prided itself in, hiring, medically trained cultural liaisons to help us bridge the communication gap, the cultural gaps, the religious gaps too. We have multiple religions that, that are represented here in the area, from obviously Christianity to Islam to Buddhism. So we have a lot of variety and diversity, especially here in the City Heights area of San Diego, where it's estimated maybe 70 different languages are spoken, in a very highly dense area of the city, probably one of the most dense areas of the city. So yes, it's been a challenge for sure to, especially when the whole pandemic started, to be able to maintain, the health centers and be able to be available for the community, to be open. And we have, we put in the extra effort. We got a actually COVID unit right at the time when the pandemic started. We purchased a building right next to us, and that's God's providence there, because we are able to use that building now to, to send all our 18 and over patients that have any cough and cold symptoms or any other, now that we understand COVID a little better, the more the telltale signs, the anosmia, the dysgeusia, the lack of taste, and all that stuff that now points towards a COVID diagnosis or differential diagnosis, that we're able to then keep our patients that are asymptomatic, and knowing that, asymptomatic spread occurs, but we have everyone is masked, we have the social distancing set up within the clinic here at our main site now, next to the COVID unit, where we can see asymptomatic patients and keep the clinic open. Even some of our family practice doctors, internal medicine doctors, are insisting that they actually see their patients in person, whereas some of our other providers and physicians have been seeing them more on the phone, and the phone's been a godsend as well too, and I'm glad that they've extended it to the end of the year, so that they're not monkeying around every 90 days trying to decide if they're going to continue it, keeping us, on, there at bay, if they're going to let us, come in or not, with the phone use and the virtual visits and stuff like that. So it's been really a big challenge too, and I definitely, that's why I said it resonated, everything, that's been said so far. But to be able to be, culturally competent for our patients and linguistically competent, we've been doing that for over 30 years now, but it's still a challenge because this is so new. The patients don't want to come into clinic, so luckily we have the phone, but then after a while they get tired of the phone, and then our providers also need more information. They need that in-person visit so that they can get better feel, for the patient care, and their vital signs, laboratories being done, imaging, even picking up medications. We went to a lot of deliveries in our pharmacies, and contact lists, everything that you hear, all those buzzwords that you hear out in society, we're also right in the middle of those, because we are definitely essential and critical for our patient populations and our communities, so that they can still remain healthy. And yes, we have seen some decrease in productivity, but not so much. We've been able to keep all our well child checks, going. We, for a while, we did, early on in the beginning, we did limit it to under 12. And then once we realized that, hey, we have good screenings, stations, going here. We have the social distancing, the disinfection protocols in place. We have testing available with, through Quest initially. Yes, we're doing the nasopharyngeal, then eventually Quest allowed us to, and they had a protocol for doing anterior nares or mid-turbinate swabbing. And then even there was always, oropharyngeal for those that were more difficult to do on kids as well, and, or adults. And so, things have just, really had to evolve and change so that we can remain open. And I think we were on a conference with you earlier in that pandemic, right, Dr. Leon, about worker burnout and stuff like that. So, like, for example, I'll give the quick example in our COVID clinic, in our COVID unit, there it was pretty much been on a voluntary basis on the providers, because you have different levels of angst and fear and concern, and so we had 3 or 4 providers that stepped up really, and and again, we just asked, and they did it, and they've been still rotating there. There's 3 now that are rotating. One of the providers has left to another job that she picked up, but regardless, we've had 3, 4 providers, since the whole pandemic started, that have just been rotating. One of them has got the COVID, but it was due to it wasn't due from a patient, it was due to a staff member, that had exposure. So we've been able to pretty much guarantee all our staff, regardless of the vaccine at the moment, prior to the vaccine, if you will, that that we do offer a very safe and a workplace, with the protocols that we have initiated and engaged with patient care. And patients also conversely are informed that that it's very safe here to come to your visit, in person. So we've been promoting that message. And now that since the vaccines have become available, out of our 500 staff, over 300 have received it. We have not made it obligatory or mandatory, as that has been looked at, and also been discussed, at the various levels, at clinic organization, whether it be from legal, medical, legal, workers' comp issues, so we've been looking at that, in terms of making it obligatory. But, as best as the science has, the vaccines do offer protection against serious COVID-19 illness, but the jury's still out whether there's much of any sterilizing immunity or preventing of asymptomatic spread. We're still waiting for that data to come out. There might be a little bit of from Moderna. Those are the vaccines that we were able to obtain, and even though we do have an ultra low temperature freezer that we were able to also obtain through our community or it's our health center partners. It's basically all the different community health centers here, the consortia here, the local consortia, that we're able to obtain an ultra low freezer, as well as 2 other pharmaceutical grade freezers, so that we can store more vaccine product. So yeah, we haven't made it obligatory, but about over 300 of the 500 staff have got it. And others are still interested in getting it, but just kind of, wait a little more for it. I guess they're waiting to see how the side effects are. And people, I already got my first dose. I'm getting my second dose on Monday. A lot of my staff, they got their second dose already, had a little more side effects, I'll be honest, but it wasn't too bad, maybe some elevated temps, and a little bit more soreness, a little more fatigue, and some more rashes, but nothing serious at all, in the staff that we've given. And then we've already given over to 300 patients as well too. The guidelines here in California, at least with the state and also our public health department, we've been doing, 65 and over, and then on a case-by-case basis. For example, like if somebody cancels last minute, then I'll grab a 22-year-old. We just don't want to waste any vaccines, and understand a lot about that vaccine equity. It's a hot topic right now, obviously. But yeah, it's been definitely a something new, something we've never ever experienced here before. I mean, I guess the Ebola kind of came a little close to that, where we did set up, screening stations, kind of shut down some of the entrances to the clinic. And, we did that for about maybe a month, and then we just kind of backed off. Now we're almost, 10 months into this thing, and it doesn't look like it's relenting so much, but some of the numbers are improving here a little here in San Diego County. But we're, as you guys probably heard, Los Angeles and Southern California was pretty hit hard in this last surge. And, obviously the holidays didn't help, Thanksgiving, Christmas, and New Year's. A lot of people were getting together, and and the vaccine's just coming out, but yeah, I'm really glad to be here. I'm just by hearing what everything that's been said, and what people are doing across the country, I'm really encouraged that we're all working at our own levels and our own ways, but we're helping our communities whereas nobody else would.
Thank you, Dr. Rodriguez. Thank you for your responses, and everything that you have said resonates. And I am quite sure that everybody is on the same boat, and at the same time we are learning together. So that's something that and that's the purpose of this type of activities. We are learning, and that's the best way to do it, while we have conversation with the health centers, and shared best practices and challenges. And Dr. Rodriguez mentioned something really interesting regarding the vaccination, the staff vaccination. And Dr. Ramirez, you and I were discussing early before going live about vaccine hesitancy, not only among patients, but among staff. So what is your experience with the vaccine hesitancy?
Yes, we had the same experience as Dr. Rodriguez seemed to have had. We have people who couldn't wait to get the vaccine, and others that were no, 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 I'm not gonna get that. And essentially, the way we handled it is that I was the first one to get the vaccine at my health center. We got the Moderna, and people took pictures and they put it up on our internet, and everybody saw that it's okay, and everybody pretty much followed after that. But there were still some people that were hesitant and were just waiting to see how we reacted, like Dr. Rodriguez said, see if we tolerated it well, if we were still functioning. And in fact, I got, after I got my second dose, the people were asking me, how you doing? How you doing, Dr. Ramirez? And so and we're always going, yes, it's great. I mean, we tell them there are some side effects that from the second dose, but something that's tolerable, and the alternative is definitely much worse. And the people are really coming around. So we're also around 70 to 75% vaccinated for our employees. We don't make it mandatory. And I think the vaccine hesitancy, as we overcome it within our staff, we can also help our patients overcome it. We get to know firsthand how we felt about it, and how relief. I mean, we felt an incredible amount of relief when we got vaccinated, and just reduce that anxiety that you were carrying around with since March in New Jersey. And then you can convey that to your patients and say, hey, we have this here. And like Mr. Taylor was saying, let's take the opportunity to vaccinate you. You're at high risk. We want to give this to you. And I recommend it. I'm your doctor. So we're trying to really push, promote it in terms of from the provider perspective as well.
Thank you, Dr. Ramirez. That's very, very, very useful. I'm going to stop for a moment and just need to check with our support staff whether we have any questions from the audience, either through Facebook or through Zoom.
We don't have any questions so far.
All right, thank you so much. Henry, another big issue is to build collaborations in the community. Work with the public housing agencies and with the other community organizations to establish either vaccination campaigns or education. So to make sure that the patients are receiving loud and clear the message. What is your health center doing to collaborate with the community, with your public housing agencies or with other organizations in your community?
One of the, we're doing several things, and this is a very important topic as we look at trying to change the culture or the tip the scales relative to patients and community members wanting to get the vaccine. One of the things we're doing specifically with CHA is working through the process where we can share and hire staff. We are in the process, I have an MOU on my desk I'm reviewing right now to share a community health worker that's going to be specifically assigned to public housing in Miles Square to do outreach in the community to help get people living in Dearborn Park to our health center to get inoculated and to educate them about the issues related to good quality health, but in particular, vaccines. On a larger scale, what I've challenged the team to do is several things. One, well, we're working with our Latino and Black caucus to have town halls. We have had a town hall last Sunday. We have a program on one of the radio programs here in Chicago, and we featured one of our providers to discuss the vaccines and address some of the myths regarding vaccines. I always like to start off with our staff to say there's good reason why people are reticent. There's good reason why people feel fearful. And we have to start from that space, recognize the reasonableness of the fear, but talk through the science and why it's good health to get the vaccine today. When you consider the risk of African Americans, Latino Americans dying 2 times, 3 times more than the average population. So part of our charge is to do 2 things, a 2-tier approach. One, provide the service in the clinic and in the community, meaning in the inoculation and testing, and also provide the information forums for discussions to be held about good health, address fear, meet people where they are, and help educate them. I also think it's important to note is on the early onset of COVID, one of the things that came out with us was, came out in terms of data for us was food insecurity. The number of patients who were really food insecure as a result of the onset of COVID. So we established a partnership with one of our local grocery stores, with Blue Cross, and we were able to deliver meals to over 3,000 families throughout the COVID season. So looking at all of not only the health issues, but those issues that plague our children and our families while suffering through this virus. We're looking for other partnerships. I just got a call yesterday regarding a private investment firm who wants to make a donation to us, again, about how we could reach out to the communities to do testing. So we're open to all ideas and all volunteers who want to help us address this issue. One of the, to put it out there in terms of if anyone has a connection, what I would love to have is a van that I could take and have go around the community to inoculate and educate families or patients or citizens. Of particular concern, not only are people living in public housing who are well isolated, but also our homeless population. You know, when I drive to work every morning, I know we all see these tent cities throughout our community. Who's looking at, who's paying attention to these individuals? Who's asking the question about their health? So there's a lot of work still to be done. And last, I'd like to leave the community with the thought, one of the items I've shared with my team is we have to learn to manage in a COVID environment, meaning by that, we must operate our practices. This is a, you know, when it first started, I looked at it as an anomaly. Now I look at it as a part of our normal business in our practice, that we're going to have these outbreaks, these events that are going to disrupt us, but we must learn how to manage and thrive in these kinds of environment. I'm reminded as our physicians have talked about Ebola, but also the water incident in Flint, Michigan. That's what we do. So I hope that helps, Jose.
It does, and thank you so much for your response, Henry. And Bob, do you have any follow-up questions for the panel?
You know, I have a number of questions which I set down here, and every time you guys open up your mouths, you cover them so thoroughly that I scratch them off my list. And I'm really happy that you talked about I guess the managing angle of it. And I guess, you know, combining social and I guess in a more detailed way, combining social distancing, you know, at work and so many people teleworking at the same time, what additional steps or techniques have you had to put in place in order to manage your staff, you know, in terms of quality control on one hand and then staff morale on the other hand, and just trying to get things done without having, you know, the team in one place? So Dr. Ramirez or Dr. Rodriguez?
I can go real quick. I think that's a great question. And especially early on when it was a big unknown and, you know, there was a lot of restrictions put in place, you know, by the state or the county or the government in general, you know, even the federal government. So our thing was to, you know, ease people into it. Yes, provide the telework, ease them to things that that were unknown or that they had a lot of maybe anxiety or fear about. So we were compared to, you know, before we're like, well, sorry, it's your job, you got to do it. End of story. We did a whole 180 on that, you know, for the employees' benefit and sake. I said, whenever they want to test, let's test them. Even if they don't have the exposures, they don't have any symptoms, make testing available for everybody. Early on, that was super important. And we got a lot of, how can I put it this way? We got a lot of mileage, you know, in terms of the morale department, you know, by just things like that, you know, not being, you know, not coming in with a heavy hand, but rather just a little more understanding, listening to what they're saying, you know, despite even if it didn't make sense, you know, sometimes you still just go with peace, you know, if they're peaceful in their mind and their heart, then they're going to be able to work, you know. So we were able to acquire a lot of PPE, thank God, early on. We didn't suffer from that as many other centers did. So we were lucky with that. And so we were able to, you know, provide the safety and the security. We went to probably overboard in the disinfecting process. You know, like every high touch area was like every 15 minutes. I was like, wow, you know, we were able to acquire all the disinfectants that worked against COVID-19, SARS-CoV-2. So that's some of our experience there in terms of the, you know, employee morale and, you know, the productivity, you know, being able to keep that up.
And
Thank
a
you, Dr.
similar
Rodriguez.
question relative to reaching out to the public, because, you know, I guess some of the key to dealing with hesitancy issues and just to getting people involved in community health in general is getting them to trust you. And in a situation where we still have social distancing and some, you know, you're limited in terms of your ability to have that face-to-face interaction with, you know, folks in the community, your patients, you know, public housing residents and so on. How have you, what techniques have you used in order to reach out to people to deal with hesitancy issues, to advertise testing and, you know, flu vaccinations and COVID vaccinations and all the rest, and also to get folks to come in for their regular healthcare maintenance? And Henry, if you've got.
Surely. One of the things we're seeing there are two responses to this. One, the initial onset of COVID, we deliberately dialed back our practice so that we only saw those who really needed to get into the clinic. So that loss was orchestrated or by design, because we wanted to care for those who absolutely needed the care the most. As things improved and we got more information about the science and the impact of, you know, social distancing and the mask, we ratcheted back up and we opened up our doors in terms of seeing more and more of the patients, including the pediatric patient population. So we're seeing less concern today, or we see more, I should say it this way, we see more opportunities today to still see patients in real time and seeing them in person. We still provide an array of telehealth, virtual care for our patients. And what's important to note is we have these dialogues in our health center, one of the things we looked at was our health outcomes. We did see an uptick, quite frankly, due to, you know, with COVID in our A1Cs. We saw that our families, their health was, you know, so we wanted to be very, very mindful of what do the indicators show us, what's happening with our population in terms of their health outcomes as we look at modifying what we're doing in terms of telehealth and in-health visits, because that's, you know, from a telehealth experience, you can't get necessary lab work. So you need to get the families in for their lab work. So we've modulated our practice. So you're going to have to get into the clinic for us to see you in order to keep you well, you know. So having absolute telehealth is just not the answer. A hybrid approach of both is really what we've come accustomed to. The battle right now for us is not so much in the testing. Everybody wanted the test. Mm-hmm. So that was not the issue for us. The battle right now is the vaccine hesitancy and communicating to our staff, not only just the hesitancy, but you know, you sometimes think you have the best systems. We had a system and have currently a system where our patients can call in and get an appointment to get their vaccine. Mm-hmm. Well, as we look closer at the data, we're still showing that we're not getting, or those patients who are highest risk are still not getting in to the degree that we would like. Mm-hmm. So the challenge for us is ensuring that those those who need it the most are given an opportunity to get into the clinic and get the test. So our staff we're calling patients, we're reaching out to them by telephone. And I share to our outreach workers and our navigators, you're not salespeople. I don't want you to sell this. I want you to make the offer. The sale comes by way of pointing to them to our community forums where we provide education about the issues associated with the vaccines and some of the historical challenges we've had with some of the issues our communities feel about, you know, being experimented on. That's where we want that to occur. But we want to get to those families who want to get that vaccine, because I believe by way of mouth, the momentum, the scales will tip, but we've got to get that ball rolling to get more and more people who've had good experiences with the vaccine, who can tell their neighbor, tell their family members, and get them to move on and get the vaccine.
Thank you, Henry. It's almost the top of the hour. I would like to be very conscious of your time. And I know that Dr. Rodriguez has a suspected case there, so he needs to deal with it. Just a final question for all of you. And I would like to start with Dr. Ramirez. And again, this is evolving rapidly. We have new faces. And one of the things that one of the topics or issues that we were discussing with Dr. Ramirez was monoclonal antibodies and HHS trying to offer the alternative either through community health centers or any organization working with health centers, including long-term care facilities. So what is your opinion, Dr. Ramirez, and what is Zufall, or what Zufall can do or cannot do in regards to the administration of monoclonal antibodies?
Yes, Jose. Monoclonal antibodies were the only thing that we had before the vaccine to really help our patients who are really getting very ill and ending up in the ICU. So we were really interested in looking at that option at our health center, and I read into it and I saw what the requirements were, and I realized that health centers that may be more affiliated, like maybe Henry's Health Center, that have a more of a connection with hospitals or with an outpatient infusion center, were more apt to be able to be successful with this. It requires special areas where you have infusions of the monoclonal and observation of the patient for an hour afterwards, with ACLS certified nurses who can respond to any emergency. So it was definitely much more than we could provide. But we looked at it, and then we also looked at our community and saw that our surrounding hospitals. We have 6 sites, or we have 11 sites, like you said, but we have 6 main counties that we serve, and very close to us, our hospitals were offering these at their emergency room. So we got very, very good at talking to our patients, explaining what this was, and sending them as soon as possible to the emergency room. And we've been very successful in getting a lot of our patients get this therapy.
Thank you, Dr. Ramirez. Henry, what is your experience in regards to monoclonal antibodies?
We don't offer that therapy in the walls of Miles Square, but we do have the systems, because we're part of a health system, meaning University of Illinois health sciences system, to transfer our patients to the emergency department and getting that care in the inpatient unit. So our connective tissue with the university allows us to do that rather effectively. Now, the one opportunity, and we've not evaluated, we do have an urgent care center that operates as part of our practice. And the question is that something we should be doing in our urgent care? And actually, I don't want to get too far out of my lane because I don't have MD at the back of my name. So I'll leave that to our physician leader to sort of come up with an answer for that for us.
No, thank you, Henry. And your experience, Dr. Rodriguez, in San Diego?
Yes, so definitely we heard about it here. Actually, I heard about it from our CEO, send me some information. Plus, simultaneously, we have been hearing about it from our consortia here. And just much like Dr. Ramirez said, those challenges of being able to, hang it, IV drip, over the course of it, the time that it takes, plus then the hour evaluation, you have to be ready for anaphylaxis. All these things are very limiting and, huge barriers that, we're not able to, surmount, or overcome. And the consortia has been able to work with one of the local hospitals to be able to set up an outpatient infusion center just for the community health center patients, or at least make it available to them, and others, of course, too. Like doctor said, we have very high risk patients, and the earlier you get this medication into them, the better, because once they start mounting their own antibody response and they start competing with the monoclonal antibodies. So it's, if you can identify a high risk patient early on, first few days of the illness, not a huge amount of symptoms, that's the ideal candidate, and that's also difficult because our patients come to us when they're a lot sicker, more so more than, than what it's recommended in terms of it being early on and, not much symptoms yet. So.
Thank you, Dr. Rodriguez. Bob?
Yeah, just have one final question for all of you, and it's really along the lines of this. We know that health center folks are busier now than maybe they've ever been, when they've got the regular work plus COVID on top of it, as I think Henry mentioned, kind of the two tiers that you're trying to deal with. We're trying to provide training, technical assistance, partnership building, research, that kind of stuff. If you could tell us, briefly what you think, how we could help you in as efficient a manner as possible. What kinds of information, for example, is it clinical information? Is it reimbursement information? Is it supply information? Is it coordination information between, your state immunization program managers and your departments of public health? There's been talk about direct shipments, for example, directly to the health centers and all that kind of stuff. So in any of those areas, if you could kind of tell us the kind of information that you need, the kind of training, and also we're trying to do it efficiently. So, because we know people have such limited time. So what's the best vehicle or the best schedule for us to provide that kind of information? And any guidance you could provide to be so helpful. Dr. Ramirez, do you want to start?
Yeah, that's a very good question. So what do we need, and how do we get it? It's so hard because there's so many different things that we're responsible for at the same time, like we're saying. I think that information is flowing. I think in terms of clinical information, I think is flowing. I think that perhaps the challenges that I find that really just distress our staff is how vaccine distribution is occurring, and how that uncertainty as to when we're going to get our next batch. And then once we get it, then we have to use it within 6 days. So we're getting 800 vaccines per week, and we're trying to figure out how to then disseminate it quickly, and everybody seeing the patients, telemedicine, in person. I'm doing the UDS, we're trying to vaccinate, we're trying to do COVID testing, we're trying to do, it's like, oh my gosh. So if that could be simplified and streamlined, or any kind of assistance with that kind of partnership, we are very grateful that the Department of Health has recognized us as a key member in the armamentarium. But we just feel completely at their mercy in many ways. So I think that relationship would be really good, the communication with the state. And obviously this is bigger than what you can. I think just the inability for the United States right now to have enough vaccine to meet the demand is the problem here. And I think that's one of the issues, but that's one thing I would like.
Yeah, and I totally agree with Dr. Ramirez. Yeah, we're trying to stave off the county from trying to take vaccines that we haven't been able to use, that we're going to be able to use next week, but they want them like before we can use them next week. After our staff, like it's been mentioned on here, calling patients, and it's only 65 and older, so we have a limited patient population group, and then a lot of them have fears and concerns, don't want them, and what have you. So it's been difficult, so we feel maybe some realistic communications with the county and the state, and also the state sending us vaccines and then the county wanting them to take them away from us because we haven't been able to meet that 65% quota. So we've been on the phone today with the county, and we're I'm hopeful that we're going to be able to hold off on them asking us to give some back after they just sent us some. The state sent us some and the county wants them back. So I don't get it. I think the state and the county need to also communicate better, and then let us have the final say, like, hey, look, here's the action plan. In a week or two, we'll be at the levels that you want us to be. It makes no sense sending us vaccines and then asking us to send them back. Like, you guys are wasting your time. You're wasting our time.
Are the primary care associations in your states any help on that issue?
They've been getting involved as well, but in terms of this particular issue, I haven't seen the email chatter or the communication yet. It's possible that they have been as we're speaking now, because they usually end up seeing a lot of updates at the end of the week.
Yeah, so dynamic. Henry, any training needs and modalities?
Yeah, you know, this conversation has been extremely helpful. So I would say, Bob, starting with two particular issues. One, best practices, because we don't have the Moderna vaccine quite yet at Miles Square, but to hear my colleagues who already have it and are struggling with, you know, all of these key issues, and so learning the best practices or how you went implementing the vaccine process really saves me from having to start from ground zero. So being able to learn from my colleagues, and if that could be documented in terms of workflows and processes, we can share those across the nation. So that's one phase. The second phase is leaning forward, thinking about what happens coming out of this or living in it over the course of time. And that is, how do we look at our workforce going forward and training them to be prepared for these kinds of circumstances? And how do we work with our congressional leaders for funding to ensure that there's more training in community health centers so we can get folks like the doctors in front of me today who will want to work in community health centers. So I think that's part of what I'm walking away with as part of this conversation, that there's such a need and will continue to be such a need in the future. We are the future in terms of healthcare, but we have to have resources and individuals who want to work in our environment. So having that focus, I think, is going to be paramount for us.
Yeah, well, thanks very much for that. And, you know, Jose's always saying, hopefully soon it'll be time to start working on life after COVID. And, hopefully with all the good work you're doing, we'll be able to do that. But I'm going to turn it back to Jose.
Thank you, Bob. Well, I would like to thank you, Dr. Rina Ramirez from Zufall, Mr. Henry Taylor from Miles Square, and Dr. Javier Rodriguez from La Maestra for your time, your support, and sharing your experiences. This has been very helpful to all who have been attending or who have been on either through Zoom or through Facebook. This session was recorded, so we are going to share this with all of you, and it will be posted on our website. So thank you again, and have a great afternoon, great evening, and have a great weekend. Thank you.
Thank you very much.
Bye, guys.
Bye.
Thank you. Thank you.
Bye, everyone. Be safe.
Too.
Thank you.